So hi everyone, my name is Aditi. I'm one of the endocrine and diabetes registrars. I'm going to be presenting a paper that was published earlier in the year in JCM entitled Effect of Testosterone Treatment on Bone Microarchitecture and Bone Mineral Density in Men, a 2-year randomized control trial. So this paper is published by an Australian group, and it's a planned sub-study of the testosterone in diabetes trial, which I believe was discussed earlier by Hesse in this journal club. So just to start off with a little bit of background. So pathological hypogonadism is a risk factor for osteoporosis and fractures in men. We do know that testosterone treatment increases bone mineral density in these hypogonadal men. And testosterone does this by stimulating, it's a complex process, but it stimulates bone formation and inhibits bone resorption through its action on the androgen and the estrogen receptors. So quite simply put, just more for easy understanding, testosterone acts on the androgen receptors, which are predominantly found on the osteoblasts, and here it stimulates osteoblast proliferation and differentiation, so bone formation. Estradiol has its action predominantly via the estradiol receptor alpha, which are again predominantly expressed on the osteoclasts. So it regulates bone resorption. Testosterone can act indirectly on the osteoclast by aromatization to estradiol. So overall, testosterone has an anabolic effect on bone. And there are multiple other growth hormones and cytokines, growth factors that can affect this process.
So can I check, Eddie, does that mean that estradiol's main activity is slow osteoclasts?
Yeah, exactly. So estradiol mainly acts to regulate osteoclast action, so bone resorption.
Thank you.
And again, late onset hypogonadism, so age-related decline in sex hormones, is associated with loss of bone mineral density. And studies have shown that this is particularly at the cortical sites, leading to increased fracture risk. So just again, different bones in our body have different proportions of cortical bone or trabecular bone. So for example, spine is predominantly trabecular, the hip is predominantly cortical. And previous studies in the hypogonadal men do suggest that testosterone increases bone mineral density predominantly in the lumbar spine, which is again inferring that it has more of an effect on the trabecular bone, which is the more metabolically active part of the bone. And most of the RCTs till date have looked at DEXA, which is our gold standard measurement of bone mineral density, or they've used quantitative CT to measure volumetric bone mineral density, which gives a 3D measurement of the BMD. However, the effects of testosterone in men on bone microarchitecture have not been described before. So just again, a little bit of reminder about the current Endocrine Society Guidelines. So the current guidelines on testosterone treatment in hypogonadism. So this is just a table that I've taken from the guidelines. So they list the conditions that have high prevalence of low testosterone and suggest that we should be measuring testosterone levels in these conditions. So one of those is osteoporosis or a low trauma fracture in young men, as well as type 2 diabetes. And these are the Endocrine Society Guidelines on osteoporosis in men, which were published back in 2012. And they suggest investigating for osteoporosis by measurement of bone mineral density in men who are age 70. So age 70 is a sufficient risk factor for low mineral density in men. And younger men, again, considered to be between 50 to 69, should also be considered a measurement of bone mineral density if they have additional risk factors. So additional risk factors include low testosterone or drugs such as glucocorticoids. And they recommend to check this by a DEXA scan at the spine and the hip, or to consider a forearm DEXA only if the spine or the hip DEXA cannot be interpreted either because of degenerative changes or other metabolic bone conditions, or because of other comorbidities such as hyperparathyroidism, which we know can mainly affects the cortical bone at the radius. And interestingly, I just put it there just because I found it interesting when I read this, is they suggest that testosterone treatment in the men who have low testosterone levels in combination with a bone drug, so some sort of anti-resorptive treatment, should be considered if they have a testosterone level as low as 6.9 nanomoles per liter. And I know the testosterone cutoffs are very controversial and different guidelines say different cutoffs, but 6.9 is quite severe hypogonadal testosterone level. So going back to the study, so they've called it the T4 bone study, so testosterone for bone. And again, this, as I said, is a planned sub-study for the testosterone for diabetes. So again, the design is quite similar to the T4DM study. So it's a randomized study, placebo-controlled, double-blind, that took place across 6 Australian academic centres, and the men were enrolled between 2013 and 2017. And the main aim of this T4DM study was to determine whether testosterone treatment prevents progression or reverses type 2 diabetes beyond the effects of a background lifestyle program similar to Weight Watchers. The T4DM study is looking at skeletal outcomes in these men. So their question is to determine the effect of testosterone versus placebo on the volumetric bone mineral density and the bone microarchitecture using this fancy high-resolution peripheral CT. And they do this at 2 sites, so a distal tibia and the radius. And they also in this article report what I've called the DEXA study. So they're again determining testosterone versus placebo using bone mineral density measured via DEXA at the lumbar spine and the femur. So just to make it easier, they're kind of reporting 2 different studies within the article, which were both sort of sub-studies of the T4DM paper. So I didn't know what high resolution PQCT is till I read this paper. So just a little bit of background on it. So it is a 3-dimensional CT modality, which is mainly for peripheral skeleton, so looking at the distal radius and tibia, and it examines volumetric bone mineral density. And it's got very high resolution. It can look at bone microarchitecture. And I think the main advantage of it is that it can actually distinguish cortical and trabecular compartments of the bone. And as I said before, I guess that knowledge is useful because different sites, different bones have different proportions of cortical or trabecular bone. And again, you know, different diseases affect certain subsets of this compartment more than the other. So it can image and, you know, tell us about the number, the thickness, the amount of structural changes within these compartments at a very low radiation dose. So it's actually 5 to 8 times less radiation compared to a chest X-ray, and also slightly lower radiation compared to a DEXA scan.
Is it lower than DEXA?
Sorry?
DEXA is very, very low. Yeah,
so it's actually lower than DEXA. So I think in the radiation dose money, it's like 0.03, and I think DEXA is a little bit higher than that, and I think chest X-ray goes up to about 40. Yeah, and it has been shown in studies that it's a good determinant in predicting fracture risk. and more so in assessing subtle changes. So looking at treatment response. So if any sort of individual changes of treatment can be better picked up on this high resolution quantitative CT compared to, for example, a DEXA. And before this imaging modality, this sort of microstructural detail could only be picked up in vivo by a bone biopsy, which I believe is still the gold standard in looking at microstructure. So just pictures speak 1,000 words and all that. So this is just to show what a high resolution PQCT setup looks like. So they have to immobilize the bone in question. So again, this is peripheral, so it's mainly for radius and tibia. So they put them in casts. And then they do what they call a scout X-ray, so just to then pick the site where they then want to take the CT slices. So these green lines, the radiographer would then choose the area of interest and then thereafter take CT images, about 110 slices or something. And then this image here just shows what so this is tibia and fibula distal, and then they can choose the bone that they want to then get further microarchitecture information on. So going back to the study, so the intervention was testosterone, and they gave an IM injection of testosterone, 1,000 milligrams. On the background of a lifestyle program, which is Weight Watchers, which is now called, I think, it's branded as WW and not Weight Watchers, and compared that to placebo. And they gave these injections at baseline, and then they gave a 6-week loading dose, and then every 3 months for 2 years without checking their testosterone levels or, changing the dose of the testosterone. In terms of endpoints, so again, I've divided this into the 2 studies that they've reported within this article. So the high resolution CT study, their primary endpoint, they were very interested in looking at cortical bone. So they've got 2 time points compared to baseline, looking at the cortical volumetric bone mineral density at the tibia. And they chose the tibia. Their rationale is that it's a weight-bearing bone. And this was done in 177 men, but in 1 center out of their 6 academic centers in Australia. And then they had secondary endpoints, again, comparing to baseline to 2 different time points over the 2 years. And this looked at other subtle parameters from the CT, looking at the area of the cortical bone, the thickness, the number, the separation, the volume, etc. And they also looked at bone remodeling markers as the secondary endpoint. So particularly they looked at CTX and P1NP, so both bone resorption and bone formation marker. And then for their DEXA study, I guess because that's the gold standard and that's what the guidelines have as our first line, they looked at the bone mineral density at the lumbar spine as their primary endpoint. And this, they did it in 601 men over the 5 centers. And this was compared only at baseline and the end of the study at week 102. So this is, again, I think a little bit controversial, but it's because it's a sub-study of the T4DM study, the inclusion criteria is exactly the same as what they had for the the testosterone for diabetes study. So these were men aged 50 to 74. They had abdominal adiposity, so a waist circumference more than or equal to 95 centimeters. They used a cutoff of a fasting morning serum testosterone of 14 or above. And again, 14 or above is within the eugonadal range. I know we have a large normal range of testosterone, but when I looked back at the T4DM study, the rationale that they give for choosing this cutoff is that they did a ROC curve analysis looking at previous studies and looked at the testosterone levels against the incidence of type 2 diabetes. And they found that this was the cutoff of testosterone below which the incidence of type 2 diabetes may increase. And they had men who had impaired glucose tolerance, so as per the OGTT, or they were newly diagnosed type 2 diabetics, again, using the OGTT cutoffs. Bit of a busy slide, but I'll just break it down. So this was their exclusion criteria. They're, again, exactly the same as their main study that was published in the Lancet. They excluded, obviously, because testosterone is the intervention arm, they excluded anyone who had a high risk of cardiovascular events, so previous history of stroke, heart failure, angina, arrhythmias, high blood pressure, a raised hematocrit, or a personal family history of thrombophilia. And again, they excluded people who had probably had testosterone in the past 12 months or had a known history of some sort of hypothalamic pituitary testicular disease or medications that could affect that axis. And overall excluded people who had abnormal liver function or severe renal impairment. One of the additional exclusion criteria that was additive for this study that wasn't for the T4DM study was that they excluded anyone who had had osteoporotic drug therapy, anything before or during the trial. This is the patient flow diagram, the participant flow diagram. So they assessed eligibility for 183 participants, out of which 177 got randomized. So this is for the CT study. And then 77% of those, about 136, completed the 2 year, at the 102 week measurements. And most of the others were either lost to follow up and a couple that they had technical issues with the machine on the day of the measurement.
And half of them got placebo for 2 years. Yeah,
so placebo was just an IM injection of saline, some sort of saline, or yeah.
Was it different? Was it obviously?
No, so they made sure it looked exactly the same. Right. Made in exactly the same vial. And interestingly, so the study personnel gave these injections to ensure compliance. So every 3 months, first week, 6 week loading dose, but every 3 months, these injections were given by the researchers. And remember, they both had weight watchers, both the groups.
Yes. Because testosterone is quite thick, we're saying. The saline looks very different to libido. I mean, it's like treacle.
Yeah, I don't think it's saline. I'm just in my head, I think it's saline, but it's just like similar, some sort of
vehicle, basically.
So, yeah, exactly. They tried to make it look exactly the same. So these are the baseline characteristics for the CT study. So the mean age, so there was no difference in any of these baseline demographics in the CT study. So mean age in both the groups was 60 years. These were, again, high risk of type 2 diabetes or impaired glucose tolerance. So these were obese participants. So BMI median of 34. They included current and ex-smokers, included people who did drink, but overall 20% of included men were drank about 11 units per week, of alcohol. They don't give us baseline calcium levels, but they did say the percentage of men that took calcium or vitamin D at baseline. I guess the study was done in Australia, so I guess, good weather. So majority of people did not take supplemental calcium or vitamin D. Interestingly, they included people that had steroids. but they do break it down. So 80%, nearly 84% in both the groups had no history of glucocorticoid use, but nearly 16% did. And then they break it down to tell us that how many were in the placebo group, how many were testosterone, and they break it down to oral, inhaled, or injectable steroids, but they don't tell us the duration. They said it could be any time, either at baseline or through the study period. So testosterone, they reported, I guess this is a good way of knowing how variable testosterone is depending on which assay is used. So the bottom one here is when they measured it at the start with immunoassay. So the mean was 10, the testosterone level, but when they measured it by mass spec, which is what then they, for all the subsequent measurements used, was 14 as the mean. Again, no difference between the two groups, but very much in the normal range of our assay cutoffs.
Did they say how many people actually had a low testosterone level? What percentages? No,
yeah,
didn't.
They didn't actually. They didn't for this study, but when I went back to the T4DM study, they did break it down, but then I guess it's not exactly similar.
Same subgroup, yeah.
Exactly, the sample size is very different between the two studies, but for the T4DM, where they had about 1,000 people, very similar mean testosterone levels, they about 20 to 30%, if I remember right, had a low testosterone. So when they say low, they use it as a cutoff of less than 11.
Thank you.
This is controversial.
Yes.
Moving on to results. So just to orientate, so on this side, we've got tibia. On the right, we've got radius. And then on the top, we've got the volumetric BMD, cortical, and the trabecular at the bottom. The solid line is testosterone. The dashed line is placebo. And here they've looked at the actual measurements of the volumetric bone mineral density. And again, just showing that they've found a significant or statistically significant difference in the testosterone group compared to the placebo group in the total BMD, which is total of cortical and trabecular, at both the tibia and the radius. This was their primary endpoint, the tibial cortical VBMD, which they did find a statistically significant difference, but then again, they found it in the radius cortex as well. Although their trabecular parameters were not statistically significant. They also present their results in a table format. So again, this is just looking at their primary endpoint, which I've just highlighted here. So cortical volumetric BMD at the tibia is what they were most interested in. And again, at 3 different time points. And here they present it at baseline, the mean plus minus SD, week 66, week 102. These are the number of, because obviously they used intention to treat analysis. They provide the numbers that completed towards the end. And then they worked out the mean adjusted difference between the two groups. And the mean adjusted difference was statistically significant for their primary endpoint, as it was for a lot of the other tibial cortical parameters. Whilst in comparison, the trabecular parameters were not statistically significant. And this was both at the tibia and the radius. Moving on to bone markers. So they reported the C-telopeptide and the P1NP. Again, what they've shown is that the testosterone group, which is bone markers, what they've shown is that the testosterone group has a reduction in both the CTX and the P1NP. And again, when I first looked at this, I thought, oh, CTX is a bone resorption marker and P1NP is a bone formation marker. So what this is actually saying is their bone resorption goes down, but their bone formation goes down as well. But which is what we see with bisphosphonates, for example, because the bone turnover goes down. So with treatment, Yeah, and I think the net effect is increase in bone mineral density, because the bone resorption has a higher decline than the bone formation decline, if that makes sense.
Yeah, I don't know if Jeremy wants to say anything a bit about that. Jeremy, you there still? About
Yeah, so because of the bone cycle, then the BMU cycle, the bone mineral unit, as Aditi's summarized it rather nicely. Of course, the two go together.
yes. If we did the CTX and P1NP weekly, would we see one going ahead of the other?
Well, what you're wondering is whether you might be wondering when you start testosterone, whether you get an independent anabolic effect that is,
yes,
let's say, like with estrogen, if you start estrogen replacement, actually temporarily you will get a rise in P1NP, rather like if you use teriparatide, which shows increased bone formation, which is in excess of the change in CTX, say. Whereas here, actually, they are really seeming to track each other, aren't they?
But they've only got a sample at the start, and then after a year,
I must say, the one thing it seems to me is that these effects are quite small. You know, when we give a bisphosphonate, the CTX halves or more. When you give denosumab, it's down by, 80%.
Yeah.
So, these effects are very small. And I just slightly wonder, if I may comment very quick, is that because actually their testosterone levels weren't particularly low? So you're sort of using this as maybe not as a physiological replacement, but as actually as a pharmacological treatment.
Yeah.
And so I'm not quite sure what this really means, given the cutoffs that you need for testosterone to help bone. Most of these men probably already had sufficient levels.
Yeah.
I don't know if that's what the commentary talks about, Aditi, but yeah, just to say, so these seem quite small changes, and those are all just those look like bone reabsorption is slightly reduced, and P1NP that just follows, the formation just follows.
Yeah, and I think these markers are so variable as well that you need at least I think 21 or 30% of change from baseline for it to be even a significant change. So as you said, with bisphosphonates, we see 60, 80, 70%. I calculated the percentage roughly, but I think it's about 30% and 20 something percent change. So just about the level that they report as anything significant. Moving on to, so that was the CT study. So this is the DEXA study, which then was done across 5 centers. And I think because the original ethics for the testosterone for DM study had DEXA at baseline, they kind of then created the study to then check their DEXA at the end of the study. So 2 time points. And this was a larger study, 611 men. And their primary outcome, as I said, was measuring the bone mineral density at the lumbar spine. Although they did check it at the neck or the femur and the hip. So these are the baseline characteristics for the DEXA study. So again, a larger study, but nothing different in terms of demographics. So, but again, they included men that had steroid use either at baseline or during the trial. And again, they subdivide this into oral inhaled injectables. But interestingly, the one thing that was different at baseline and statistically different was their testosterone levels. I'm not sure if clinically this is different, but in the testosterone group, they had a slightly lower testosterone level at baseline compared to the placebo group. But again, in the eugonadal mean average levels. And then they provide the T-scores at baseline. And as you can see, and I think Dr. Cox mentioned earlier, these men actually have normal baseline T-scores at each of the different sites. And that's despite them being obese and despite them having impaired glucose tolerance or early type 2 diabetes. So these graphs are showing the 3 different sites. So A is lumbar spine, B is total hip, C is femoral neck. And this is the actual aerial bone mineral density in grams per centimeters squared. And again, testosterone versus placebo, and a statistically significant difference at all 3 sites. But the highest treatment effect was at the lumbar spine, and I think this was about 1.8% from baseline. Moving on to T-scores. So again, each of the 3 sites, 2 time points, placebo to testosterone, and then the mean adjusted difference, all statistically significant, but changes of, small changes. So it's just saying bone went from having a normal T-score to even a more normal T-score. So within the normal range of our cutoffs, I guess. And then they reported the testosterone and the estradiol levels. And again, I found this quite interesting. I assumed that if we gave testosterone to someone who had normal testosterone and we're giving them without measuring their testosterone levels or adjusting, I guess they're in the normal range, so you're not really adjusting to anything, but their levels, despite 2 years of having IM testosterone injections, only went up by, I guess at maximum, adjusted difference of nearly 2 nanomoles per liter.
So presumably that suppresses their endogenous production.
Yeah, I guess your body wants homeostasis. Yeah, so, and I think they didn't report it here. They didn't look at LH, FSH, but looking back at the DM study, their LH, FSH did suppress. So yeah, so I guess LH suppression is a marker of, I guess, reduced Leydig cell then production of testosterone, yeah. In terms of adverse events, and I think that's probably the main thing this study probably adds is to the safety data of testosterone in a way. The main adverse event was, as expected, I guess, was raised hematocrit. So they had a cutoff of 0.54% or above, and they found that 20% of men that were assigned to the testosterone group had a raised hematocrit compared to only 1% in the men that were assigned to the placebo group. And what they did is in their safety protocol, they were checking these every 6 months, and they said if it reached 0.54%, they stopped the testosterone, but still carried on monitoring and these men and still carried on having the end study visit. What I found interesting is that, so prostate, there was no difference between, prostate cancer or BPH. If anything, there were 3 men in the placebo group and 1 in the testosterone group that had prostate cancer. Again, they pooled their cardiac events as together with all these different, so cardiac death, MIs, etc. So there was no difference to, like, if they pooled it, but just looking at the arrhythmia, there was 7 men in the testosterone that had arrhythmia versus only 1 in the placebo group. And I wonder if they just reported this separately, that would probably be statistically significant. And I don't really know if anyone, whether the only thing I could find just by doing a quick lit search was actually testosterone deficiency is associated with high risk of AF and arrhythmia, and replacing someone's testosterone reduces that incidence, but nothing that I know of that giving testosterone to a normal eugonadal man would increase their arrhythmia risk. So just to conclude, this is what the authors conclude, that in men who are 50 years of age or above with pre-diabetes or early diabetes, testosterone treatment given as an IM libido injection over 2 years increased the volumetric bone mineral density at both the tibia and the radius, and the main effects were at the cortex. And they do report significant treatment effect sizes of 2.9% to 3.1%, which then they compare it in their discussion to other studies in the literature that have used anti-resorptive treatment. And most of those studies are on postmenopausal women who have a low baseline bone mineral density. And the effect sizes that we see in that group ranges between 0.3 to 3.8%. So comparative. Obviously, conflicting to previous literature, they didn't find anything significant in the trabecular bone parameters, which is what's mainly reported, that spinal, which is mainly the trabecular bone, has improvement with testosterone.
Yeah.
Obviously, the study has its strengths. It is the largest, one of the largest and longest testosterone trials we have till date. And it's the first one that's actually looked at bone microarchitecture, so subdividing it into cortical and trabecular microarchitecture. It did have substantially large numbers and a good participant retention of about 77%. And as I said earlier, they obviously injected both those injections by the researchers, so taking away any compliance issues. I guess a lot of limitations as well, and a lot of things to discuss, but they obviously haven't, and we don't have any data from a randomized control trial that has looked at testosterone effects on fracture risk. And I think that's partly maybe because of we need a very long study. And I think because of the safety concerns of testosterone in older men, that study has not taken place yet. So obviously this is not designed to look at fracture outcomes. And, all these men had normal baseline T-scores, so you cannot extrapolate this to men with osteopenia, osteoporosis. I guess it does look at a high risk group in some way because they all had impaired glucose tolerance and were obese. The upper age limit was 74. And if you remember, when I looked at the osteoporosis guidelines, 70s, they cut off for, thinking about osteoporosis in men who don't have any risk factors. And again, this high resolution QCT, it's a research modality, experimental. It's not used in clinical measurements yet. So it's looking at peripheral skeleton. So whether the measurements at the peripheral bones reflect the axial skeleton. There are some studies that say that there is a moderate correlation between the two. And this Weight Watchers WW life program that they were doing, most of this was self-reported. So again, that introduces a little bit of bias. And I guess most importantly, being a testosterone study, none of the men that were included had symptomatic testosterone deficiency. So again, as Dr. Cox has alluded to it, it's pharmacological, supraphysiological. It's actually not a replacement. And their main levels were about 14, which compared to most of the other significant trials is quite high. And obviously, if you look at the osteoporosis guidelines of 6.9, so nearly double that. So you can't really apply it to pathological or age-related hypogonadal men. And I don't know what everyone thinks about this, but they do say that they measured trough levels of serum testosterone, so prior to the next dose every 3 months. So whether it may underestimate their blood testosterone levels, and maybe the overall exposure to the testosterone was a lot higher than the levels that we can see, which was a change of about 2 in the serum testosterone levels.
Yeah. So the other thing is the bone density scans. So the DEXA, as I was saying, on the spine.
Yeah.
You can't do a QCT on the spine because the amount of radiation that you get will be vast. Because CT is much more radiation than DEXA. DEXA is a tiny amount of irradiation. But of course, what you receive, if it's your arm in an outstretched thing like in the picture, then your gonads don't get very much at all. I think that's what they're talking about. Whereas you can't do that with a back.
Yeah, although there are studies, I think completely, yeah, right in terms of that it does have high radiation, and high resolutions peripheral, although just looking at peripheral skeleton has a lot less radiation, even less than a DEXA. So I guess it's got that advantage that you can have multiple measurements over a longitudinal study. But there are studies that have, before this only came, I think, in 2005, this high resolution CT. They have done studies with CT measurements of lumbar spine, but again, limited by the radiation exposure. And lastly, I think this is my last or second last slide. So they have shown, I guess there's a lot of things to, it's a controversial study looking at men who didn't have underlying low bone mineral density and not underlying low testosterone levels, but yet they have shown consistently increased cortical bone treatment effects, which, cortical bone does comprise 80% of the skeleton. So I guess they're arguing that does high testosterone levels in a subgroup of people that probably have, diabetes or obesity, still has, benefits at the microarchitecture. But again, we don't know whether that translates to any significant fracture outcomes.
Aditi, are we saying that this is all through estrogen effect? Because in men, the bone mineral density and osteoporosis risk and fracture risk go very well with estrogen levels later in life. And what you're seeming to show is this is an anti-resorptive effect based on the bone markers, etc. So it's really acting through increasing their estrogen levels. Did they do a bit of analysis on that?
Yeah, so they did report the, I'll just go back to it, sorry, because I can't remember the numbers by hand. So here is where they looked at serum estradiol levels through the study. And as seen, there was a positive, so significant difference at the end of the study in the levels in the testosterone groups versus placebo. And I guess that's probably by testosterone aromatizing to estradiol. And these were obese men, so I guess they've got higher adipose tissue. And obviously they included men with higher central adiposity as well. They didn't report it in the paper, but they include one line saying they did analysis by baseline testosterone and baseline estradiol levels at the start and found that there was no difference in the outcomes. Hence, they didn't report it. And I think I've already mentioned most of this, but the only other study that I thought could compare to this study, but although looking at hypogonadal men, with this large testosterone trial study by the American group, which was, I think, over 8 centers. But I guess the difference is they found trabecular lumbar spine improvement compared to this study that shows cortical bone. Then again, I guess that then talks about whether that's the estradiol effect versus the testosterone anabolic effect directly on the osteoblasts. But I wonder whether some of these differences are because of the way the testosterone was given, injectable versus gel, how long it was given for, the age of the men. Obviously, the testosterone trial study had men who had a mean age of 70 versus here, which were 59 or 60. And I guess most importantly, they were deficient in testosterone versus the group here that were eugonadal. And whether eugonadal men aromatize more of their testosterone to estradiol because they don't need their testosterone to dihydrotestosterone. I don't know. I'm just thinking out loud here. And I'm going to end with copy pasting the last 2 lines of the journal of that article, where the authors state that, of note, from a clinical perspective, our findings are clearly not meant to endorse testosterone treatment to improve skeletal health in men without pathological hypogonadism and with a normal serum testosterone.
Unfortunately, it'll do just that, won't it?
That's exactly what it's going to do when it goes to the papers and to the lay public.
Yeah.
I think what we can say, Aditi, is that that was really beautiful. You very clearly outlined that we should always be thinking of testosterone and doing bone mineral densities in our hypo-PIP population as well as osteoporotics. And also to say that within osteoporosis, what we've tended to find is that really hypogonadal men on replacement get quite stunning increases in bone mineral density, probably more than we see with any other treatment. I mean, it's not uncommon for us to see people gaining more than 20% bone density at lumbar spine, and not so much at the hip, but you know, it is a really huge effect when they're properly hypogonadal. So yeah, but I just think in the PIP cases, we tend to forget that both growth hormone and testosterone deficient, and both of those are going to lead to change in bone density. And thank you for highlighting that. Actually, yeah, we should be looking at all. It should be part of our protocol, not just MRI pits, but actually thinking of all their densities.
Yes.
Yeah, and I guess we don't measure radius and tibia, you know, so we don't really know what goes on there in the hypogonadal men, you know, when we treat them or after treatment.
Absolutely.
Yes. Do you think a DEXA would be any good though? On the wrist, I mean, we do for parathyroid patients, for example, but that wouldn't help you because you wouldn't like, would it?
If I might give you an example, in primary hyperpara patients, DEXA is only good at the diagnostic stage. Post-op does not improve, so it doesn't show you treatment effect. And that's because it's QCT would.
Yeah.
And that's because actually the diameter and the size of the bone basically changes post-operatively. So the cortical envelope moves peripherally, and that actually increases the strength of the bone. And you don't see that on an aerial bone mineral density. So I'm a bit unsure how radial would really help you. I tend to think it as a diagnostic one. I don't know enough on that post-testosterone replacement.
Right. Thank you.